Thanks very much, Marcello, and thanks for inviting me to this beautiful city. Mr. Chairman, ladies and gentlemen, I'm really pleased to be here, and also to see a good friend and colleague, Alan Jaffe. We like to spar a bit, although it's always very friendly. Not really, but I thought I'd say that. So I listed my disclosures, but they have nothing to do with this talk. I always just fully disclose anyway. So as Marcello said, I've been very privileged to run NIH-funded trials, and I've moved progressively from cardiogenic shock, which was discussed this morning, to stable post-MI, occluded artery trial, and now, in my older age, I've moved to stable ischemic heart disease. So the question is, and I'm really going to use the next 20 minutes to discuss the foundation for why NIH has invested a lot of money in a very global, very large trial targeting 8,000 randomized patients. That number is really unheard of. So what are the goals of treating stable ischemic heart disease? I'm not going to really talk about the diagnosis. You know how to make the diagnosis, a clinical diagnosis, right? We do stress testing to confirm, we can do cath, and I'll show you some stress test data later. But what are the primary goals of treatment? Well, it's to improve survival, to improve angina and quality of life. It's to prevent MI, but only because that's correlated with reduced survival and reduced quality of life. Otherwise, patients really don't care. Now, fortunately, all the wonderful talks that came before me means I can skip any discussion of type 2 MI and the challenge of making MI in stable ischemic heart disease. So you'll see, I'll just run through those slides because everybody talked about it wonderfully. All I can say is that this has made my life as a clinician and clinical trialist miserable. High sensitivity troponin. Okay, so management of stable ischemic heart disease. Number one, we optimize medical therapy and lifestyle changes. And the question is, do we do cardiac catheterization just for failure of optimal medical therapy? Or is there a role for a strategy of routine revascularization in addition to optimal medical therapy when you've made the diagnosis of stable ischemic heart disease? That's the question. So what are the data we have to answer that question? Well, this goes back to the 1970s, late 1960s, the bypass surgery versus no bypass surgery trials. And this was put together by Salim Youssef. We have the VA study, which showed no benefit. We have the coronary artery surgery study, which showed no benefit. And the European cooperative study, which included more symptomatic patients, more positive early stress tests, was significantly in favor of bypass surgery, so putting them all together, there was a benefit. The question is, the relevance today is unclear. There was minimal or no use of effective medical therapy, very little use of aspirin, no use of statins, very little use of beta blockers, no use of ACE inhibitors. So it was really cabbage versus no cabbage, nothing. We now have the era of intensive medical therapy, COURAGE, Barry 2D, and FAME 2. So you all know the COURAGE trial. PCI, as a routine strategy, did not reduce death or MI in stable ischemic heart disease patients, and I can show you the survival curve. It's the same for the two groups. Very importantly, the issue is a routine strategy, not never doing the revascularization. So in COURAGE, a third of the OMT group, optimal medical therapy, had PCI over 4 years of follow-up. 1 out of 5 had repeat PCI in the PCI group, but 2/3 never needed it in the OMT group. This is a network meta-analysis, which includes COURAGE, but does not include Barry 2D, of 61 randomized trials of over 25,000 patients that found no difference in death or MI between PCI versus medical therapy. You have plain old balloon angioplasty, bare metal stent, drug-eluting stent. The only thing that was benefited was less cabbage, but no difference in death or MI. So these authors concluded evidence supports optimal medical therapy as appropriate initial management approach to stable ischemic heart disease. Then came Barry 2D, trial of diabetics prompt revascularization did not improve survival in diabetics with stable ischemic heart disease. So here is the prompt revascularization versus medical therapy initially as a strategy, no survival benefit. Now, once again, the revas group at 1 year the medical therapy group at 1 year, 1 out of 5 required revascularization. So 80% by 1 year did not. By the end of 5 years, 42% required it. Once again, 58% did not, but it's an initial strategy. It's not that you never do it in these trials. If you look by the PCI stratum and by the CABG stratum, the primary endpoint survival, there was no difference, and no difference in CABG either. Now, we all worry about certain angiographic subsets that are worse than others. So these investigators have looked at the risk of death or MI based on angiographic severity, including proximal LAD, which we're all concerned about. The bottom line is there was no difference for PCI versus optimal medical therapy in either COURAGE or Barry 2D for proximal LAD. First of all, it was not an independent predictor of death or MI in this era of optimal medical therapy. The hazard ratio was similar for LAD and other stenoses, PCI versus OMT. And there was no suggestion that PCI or proximal LAD reduced the risk of death or MI and in COURAGE. And there was no difference in death or MI based on the number of vessels diseased or by Jeopardy score. And there are 2 are presentations and 1 is a publication. Now, on the other side of the equation, we've had major advances in optimal revascularization. We have improved PCI use based on FFR guidance from FAME and DEFER, greater use of drug-eluting stents, including the newer generation stents, which appear to have a lower risk of thrombosis, and better case selection based on the syntax score. And we have FAME-2, which was fairly recently presented and published, looking at FFR-guided PCI versus medical therapy in coronary disease patients who were stable. They could be enrolled as early as 1 week post-MI. So this is different than the ischemia trial. We exclude patients who are within 2 months of an ACS. And these are patients who are clinically referred for coronary angiography. The primary outcome was composite of all-cause death, MI, or urgent revascularization. And as you know, the PCI group for that primary composite endpoint was superior to medical therapy alone. The primary endpoint was driven by urgent revascularization exclusively. 52% of the urgent revascularization patients had no evidence of ischemia on ECG, and their cardiac markers were negative. So FAME-2 perspective, there was no difference in death or MI. Very underpowered, but the MI hazard ratio for PCI versus OMT was 1.05, p-value 0.89. FAME-2 randomized patients after catheterization. The physicians treating the OMT assigned patients knew the anatomy and the FFR results. The patients knew it also. If the primary endpoint of COURAGE and Barry 2D had actually included revascularization procedures, including urgent revascularization, there would have also been a significant difference in the 2 groups. And we don't know the success of medical therapy or risk factor control was not reported. So I pose the following question, which has stumped many, including me. Why have randomized trials not demonstrated a survival benefit for fixing a stenosis in stable ischemic heart disease? It just seems intuitive that it should improve outcomes. Well, first of all, there's a dissociation between the angiographic or the physiologic severity of a stenosis and the underlying atheroma and the propensity to become a culprit lesion. Atherosclerosis, as you know, is a systemic disease with diffuse coronary artery involvement. And medical therapy has changed the underlying biology and natural history of atherothrombotic disease. So here's a paradigm that several have published. This one is from Peter Stone. Looking at severe obstruction, the paradigm says causes angina, but no plaque rupture, versus mild obstruction, no angina, likely to plaque rupture. So here's your angiogram. This is what we all get very nervous about and want to do something about. It's a severe fibrotic plaque with severe obstruction, no lipid, this fibrosis calcification, this is what it looks like, gives you exertional angina, positive exercise test, and you revascularize as needed for symptoms if they can't be controlled with medical therapy. The paradigm says that here and here and here, when you do IVUS, you see remodeling, lots of plaque, but angiographically it's a minor obstruction, eccentric plaque, lipid pool, thin cap, prone to rupture, cause acute MI, unstable angina, sudden death. We need pharmacologic stabilization, early identification, and the question is, what's the role of revascularization? Now, there are 4 studies that looked at the coronary stenosis prior to MI. They had angiograms before and after the MI. 68% of those infarcts had less than 50% stenosis preceding the site of the MI. 18% had a 50 to 70%, and this was published by Falk way back. I'm going to skip the challenges in making the diagnosis in stable ischemic heart disease because others have covered it so well. I'm going to skip my slides on troponin elevations and correlation with mortality. You've seen it, the Dallas Heart Study. This is interesting, though, because clearly LVH, which a lot of the blacks have, and hypertension, LV mass were all independently associated with high sensitivity troponin elevation, whereas prior MI, angina, coronary artery calcium were not independently associated with high sensitivity troponin. For me, it's a nightmare, but okay. So can we improve outcomes? Step 1, improve prescription of and adherence to guideline-directed medical therapy and lifestyle changes. We and our patients do very badly. I've got a lot of slides on how badly we do, but in 20 minutes I don't have time to show you. You know what optimal medical therapy is: antiplatelet agents, anti-lipid, mostly statins, ACE, beta blockers. Lifestyle changes, incredibly important. Mediterranean diet, I'm convinced. I'm on a Mediterranean diet, lots of olive oil every day. Risk factor goals, you know. How do we do? Well, this is a study from the US looking at patients who have elective PCI for stable ischemic heart disease. And look at the dismal percent that have optimal medical therapy, less than 50%. Then Courage gets published, and here you go, elective PCI, dismal and no change. And optimal medical therapy was defined as being on aspirin, beta blocker, and statin. So we don't do well, and even Courage patients did not have 100% optimal medical therapy. So now the question is there any high-risk group of stable ischemic heart disease patients other than left main disease in whom a strategy of routine revascularization improves outcomes in the era of modern medical therapy? Well, this subgroup with a lot of ischemia was suggested as the group to focus on by a classic paper from Cedars-Sinai, Rory Herkomovich, Dan Berman. So it's an observational study that showed that revascularization was associated with lower risk of cardiac death only in those with more than 10% ischemia on perfusion imaging. So here's cardiac death, log relative hazard. Here's percent ischemic defect with stress. Now, risk goes up as percent ischemic defect goes up. But when you were selected for revascularization on clinical grounds, this became flat, which is a little unrealistic because risk should still go up. Whereas medical therapy, there was a higher risk with higher ischemic burden. The curves crossed at 10%, and that is the threshold we are using in the ischemia trial. Now, so what about ischemia and the risk of MI death? Well, moderate severe ischemia has been thought to be a marker for a higher risk of death. That's one study that showed it. Now, newer data challenge this, and I'm going to run through pretty quickly with you the newer data that challenge this notion in the era of optimal medical therapy. But first, let's go through whether this increased risk is related to adverse effects of ischemia directly, occlusion of a severe stenosis, because severe stenosis can occlude, arrhythmias, or whether more severe ischemia is a marker for atherosclerotic burden and more vulnerable plaques. We don't know the answer to this. So some new data. This is the COURAGE baseline nuclear substudy. You've previously seen the paired serial nuclear data, which required patients to come back for a second scan 6 to 18 months later. Here are data on the subset with moderate to severe ischemia at baseline without regard to whether they came back for a second scan or not. Here are the patients with no or mild ischemia. Here are the patients with moderate to severe ischemia. The first thing you see is there's no difference in outcome based on ischemia. The second thing you see is that the PCI versus OMT have similar curves here. PCI, death or MI, OMT, death or MI, no difference. This was about 450 patients. This is about 900 patients. Underpowered, but interesting, and forms the basis of equipoise for the ischemia trial. Now, these were site-determined levels of ischemia, but they had 189 patients with core lab interpreted moderate severe ischemia. PCI event rate for death MI was 24%, OMT 21%, hazard ratio 1.19. Now, perhaps you've seen the recently published STITCH data. STITCH was a trial of ejection fraction less than 35% with or without clinical heart failure, randomly assigned to bypass surgery or no bypass surgery. There was no difference in patients with versus those without stress-induced ischemia in terms of all-cause mortality or other endpoints. So here at baseline, they had ischemic group and no ischemic group, and you can see the death or cardiovascular hospitalization rate for the two subsets of 143 and ischemia 256 patients. A big surprise. Also very surprising is the survival by presence of ischemia and treatment group. There was no difference in the treatment effect between CABG and medical therapy group for mortality or any other clinical endpoint for those with or without ischemia. So the overall trial results, here's the hazard ratio, applied exactly the same, whether or not you had stress-induced ischemia at baseline or not. Here's the no ischemia, med versus CABG. Here's the ischemia, med versus CABG. Very interesting. You can also see that these outcomes are not any worse overall than those outcomes. So it's re-questioning this notion that ischemia in and of itself is so bad. It may be that all in the era of optimal medical therapy, there are other determinants that overwhelm the independent value of ischemia. So what's the best initial management strategy for higher risk patients with stable ischemic heart disease? What's the evidence that early revascularization improves prognosis among higher risk patients? Well, to answer these questions, the ischemia trial, International Study of Comparative Health Effectiveness with Medical and Invasive Approaches. I'm the study chair. David Marin is the co-chair and PI. Very importantly, we have a co-PI that includes a very broad tent of opinions and areas of expertise within cardiology. So we have Bill Bowden, who is PI from COURAGE, surgeon Bruce Ferguson, Bob Harrington, Greg Stone, and David Williams, 3 interventional cardiologists. So patients with at least moderate ischemia on stress imaging and ejection fraction greater than 35%, so a different cohort than STITCH, who are stable, not within 2 months of acute coronary syndrome, stable ischemic heart disease, who have an acceptable level of angina on medical therapy are eligible. And the primary aim is to determine whether initial invasive strategy of cath and optimal revascularization, as I defined it before, plus optimal medical therapy, is superior to a conservative strategy of OMT alone with cath reserved for OMT failure. So it's not that you can't do cath ever. It's if the patient has symptoms refractory to medical therapy, you do a cath and you do revascularization. If they have unstable angina, an MI, clinical need, you do it. The primary endpoint is the composite of cardiovascular death and MI. For patients who do not have renal insufficiency, there'll be a blinded CCTA to rule out left main disease and confirm obstructive disease. Very interestingly, Of those with core lab confirmed at least moderate ischemia who get a CCTA, 15% have no obstructive coronary disease, 15%. It's a real phenomenon. Cardiac syndrome X. We are targeting 8,000 randomized patients that dwarfs Courage 2200, Barry 2D 2400. We're targeting 8,000. The average follow-up is anticipated to be 4 years, and of course, Italy is an important partner. Aldo Maggioni is the country leader. You see the sites here. I've highlighted names of what I think are the attendees. We've got a good representation from Forli. Here are their number of enrolled patients, randomized patients, and we hope and expect for Italy to make a very big contribution. So we actually need all of your support because there are a lot of biases toward one therapy or another, and we need your support to answer this important question. Globally, we have over 260 randomized to date, so we're well on our way, and we're actually on target. So the management of stable ischemic heart disease, I would conclude by saying we optimize medical therapy and lifestyle changes. We've got a lot of improvement to do in this domain. The role of routine revascularization is for significant left main stenosis. By the way, of those patients with core lab confirmed moderate severe ischemia who undergo CCTA, about 9% have left main. And the actual proportion of stress tests that have moderate severe ischemia is tiny. It's less than 5%. So the left main prevalence out there, if you do the math, is really, really, really low. Angina refractory medical therapy, clearly, you need revascularization. If the patient is dissatisfied with their quality of life on medical therapy, you need revascularization. Whether moderate or more ischemia routinely needs revascularization, that is to be determined, and I look forward to collaborating with you over the next several years to answer that question. Thank you.